the borderliner is the female predator, just like the antisocial male is a predator. We've no problem calling him a predator. With the borderliner, they will go in, they call it love bombing.
Yes.
But it has nothing to do with love.
Yes.
So they'll see this, your smallest facial expressions and say, oh, he reacted to that, more of that.
Welcome to the Brad Carr Podcast. My guest is Dr. Hannah Spier, a psychiatrist, an expert in personality pathology, and the host of the popular show, Psychobabble with Spier. Dr. Hannah Spier, in your words, what is a cluster B personality disorder?
Yeah, so cluster B, so you have, when you talk about personality disorders in the DSM, you have clusters A, B, and C. So that's, I think, where you should start. So cluster B, that's borderline, histrionic, narcissism, and the antisocial personality disorder. So that's really good to have clear, because a lot of them are mixed up. And I think, I like to talk about cluster B traits, because you don't just have a textbook narcissist or a textbook borderline. It's all, you have. I've never had a borderline patient in therapy who didn't have narcissistic traits, who didn't have that. And it's because the personalities, the traits are so close together. There's really just a very, very small distinction to make between them. And that's often just academic. So I just think when you talk about cluster B traits is a much better way of describing this type of personality. And in cluster A, they're the ones typically, I'm just going to make it really simple, the ones who live alone in the woods. Like the ones, they're very different. They're very eccentric. They're the schizoid, the ones who have magical thinking. And then the cluster C, they're the ones who are very anxious, the obsessive, the dependent personalities. And they're very different from the cluster B. Some could even argue oppositional to the cluster B.
Mhm.
So, yeah. So that I would say, does that answer the question?
Yeah, let's go deeper on it. So how do you relate the cluster C to the big five personality traits, just to get more of a picture?
That's a very good question. Right. So they would be, it's different, right? Because I would say that the dependent personality is quite different from the obsessive compulsive personality. So the anxious and the dependent, they're very high in neuroticism. So the big five, should we go through them just quickly
Sure.
in case the listeners aren't, I don't know how familiar they are, right? So you have neuroticism, you have conscientiousness, extroversion, agreeableness, and the last one, what did we do? Neuroticism, agreeableness, conscientiousness, and extroversion. Extroversion, right. And so they would be very high in neuroticism, and the dependent, they would be very agreeable. That's why they're so dependent, because they're people pleasers. And you have to think, when you have personality disorders, they're disorders because these traits are so excessive that the behavior that comes out of these traits, they make you dysfunctional. So they create impairments in every single area of your life, and that is diagnostically relevant. That is very important to remember. You can't call someone disordered unless they really are impaired in their everyday life. That means these traits cause behaviors that make them not have a long-term job, not have a long-term relationship, not being able to make anything work. People, they're alienated from people because they're exposed and people don't want to have anything to do with them anymore. So that creates then the development of other types of mental disorders like depression, like anxiety, because everything just stops working because of the behaviors that follow these excessive, these extreme traits. So the personality disorders, they lie on the extreme of all the different, the five personality disorders. So that's why we have to be careful with throwing out this is personality disorder. So I would say the cluster A, then you have very agreeable and very neurotic. And so that's if you want to look at the difference between, for example, a borderline patient and someone who's a dependent personality, it's that level of agreeableness. So the borderline and the cluster B, they're very low in agreeableness and very high in neuroticism, as are the antisocial personalities in the cluster B, as are the narcissists. So they have that in common in the cluster B. They're very low in agreeableness. And what that does is that they don't internalize rules and social norms. They don't care. So that's why, when you're in a room with someone who has a borderline, you sense immediately that they're willing to go much further than you are to control the environment around them. They will have that tantrum in the middle of a crowded train, no matter what. They don't care about what people think. They care about dominance in the situation. Whereas the dependent personality in the cluster B, they care very much. They care so much that they cannot for the life of them stand up for themselves. So if you have them in therapy, that's all you do. You have to just make them brave enough to say no even once. So they get into these relationships where they just give and give and give. And then what happens is they become resentful because they do have their own needs and their opinions, but they are pathological people pleasers. Right? So that's sort of the difference, I would say, if you get down to it, between this cluster A dependent, agreeable personality and the borderline, histrionic, narcissist. They are very low in agreeableness.
And Hannah, with these personality disorders, these cluster B personality disorders, it seems that there's a distinction in how men and women are seen with them, that perhaps women are more often lumped into borderline, men more often lumped into narcissistic personality disorder. What is the difference in how men and women are viewed in the cluster B personality disorders?
Yeah. So I would argue that the borderline, it's at least 75% represented by women. And that is because of how we move in society, how we act out, how we show aggression, for example. So I would say, and I've made the argument that the borderline personality is the female version of antisocial personality disorder. Antisocial is very, very often men because they're outwardly aggressive, so they're very often incarcerated. Right? Prison populations are full of, if you have data on this, full of antisocial personality disorders. Because that you need to have that propensity towards outward aggression, violence, and whereas the females, they, because we're more fragile, will tend towards relational aggression, which is gossip and false accusations and relational maneuvering to cause harm where it's disguised. It's not visible. So we don't want to become visible because we're more fragile. So that's pretty well known. And so if you really go through the diagnostic criteria of borderline versus the antisocial personality, you'll see that they're really quite similar. So, they're both quite manipulative. They're both very low in agreeableness, so they have that disregard for rules, but they just go about it in a different way. So when it comes to neuroticism, that's where you really see the difference. So the borderliners, they're said to be like 95th percentile neurotic of the people with 95th percentile, and also very, very low in agreeableness, and then very, very low conscientiousness. So that has to be a part of it. And I think that's actually more important than the high neuroticism. You have a lot of neurotic people who don't have this borderline pattern. Like I talked about before, if you pair it with agreeableness, you get something completely different. But it's that, so they have that low agreeableness, low conscientiousness in common with the antisocial personality, which means that they cannot follow anything through. So long-term commitments become very difficult. Everything is about what's fastest in the moment. How can I move the environment around me to satisfy my needs in the moment? And whether I do that through relational aggression or through physical aggression, that becomes the difference. And so really the difference lies in how females and males perpetrate aggression.
Wow. So in this model, then we would see that it's all about aggression, all about getting what you want, but that the more feminine expression of that would look like borderline traits, whereas the more masculine expression of that would look like antisocial personality disorder, or, as we say, a sociopath.
I think so, because take the so the counter argument to that will be, well, no, because the borderliners, their aggression turns inwards. They have internalized symptoms. Like they become depressed. They have this chronic emptiness. They'll make it, but it's also formulated in a way to also remove that moral weight from the borderline pathology. We don't have that concern with men, with the antisocial personalities. We have no problem calling them all kinds of names. With the borderline, we really focus on those internalized symptoms. But take the scars, for example. That's sort of the hallmark of the borderliner. Oh yeah, they're the ones who cut themselves. And not all of them do. It's just so that you can sort of place them, right? Oh yeah, so that's sort of, because they do tend towards self-harm, and that is in the diagnostic criteria. So I think it's okay to use that as an example. And now people will say, well, you see, the scars, they cut themselves, that doesn't cause anyone else harm. That doesn't have anything to do with the environment, because the scars, they'll even leave when they're alone. But the scars have a different functionality as well, because you will see they do it differently, of course, but the scars are easily shown in the aftermath to the environment around, and it signals something. It signals I'm capable of violence, starting with myself, and it's this warning signal. So it is in the end also used to manipulate the environment, just in a different way, just in a very female way.
Yes, I've been around one of these people, and the sense that I got was that she would be willing to take herself as a hostage to get what she wanted. And it seems that the cutting is a signal of that.
Yes, it is. I would say that it is, as well as, face tattoos and face piercings. It's this, I'm capable of going the extra mile.
Mhm.
So be careful.
Yeah. And I've heard you say that these aren't like other illnesses. They don't appear after an unpredictable or extraordinary event. They appear gradually over time. How do these things develop over time?
Yeah. So you have to start with that genetic predisposition, which is they're the personality traits. That's 40 to 60% genetically governed. So you're born with this constellation, extremely high neuroticism, low agreeableness, low conscientiousness, and then varying extroversion. I mean, I've really only seen quite high extroversion, which is where the seductive element comes in. The charm that, it hooks you. You have to have a level of extroversion to get that. And then you need the environment. And I think that the borderline pathology is not what they say that it is caused by trauma. And they like to talk about trauma in relation to borderline because it does exonerate the person a little bit. But this is not at all a fact. If you look at the data, there are too many borderliners who haven't had any trauma for that to really fly as a, it's genetic plus trauma. So I really, I'll dispute that assumption. So I think if you've been around any borderliners, you'll notice that there's a level of them being quite attractive. I think that has an influence in how they are raised, how they meet the world. And this is, the traits. What are the traits? The traits lead to behavior. So we have to look at it from a behavioral point of view. These are strategies that develop. They're behavioral strategies. They see, if I escalate, because that is another hallmark of the borderline, they do escalate, or they're emotionally very volatile. So they'll have this outrage, very, very similar to how a 2-year-old has a tantrum. Right? And it's every time that escalation works, they learn. When I escalate, the environment moves around me. And it is sort of the fastest way out. That doesn't mean that that's pleasant for them, right? That doesn't mean that they're not subjectively suffering. This isn't comfortable. And I do think that they're also suffering, but it also means it works. It is a strategy that works. And especially for kids who are very charming, they're very attractive, they don't get the same kind of, they're not raised the same way. They do get away with things that less charming kids don't get away with. That's just, if you have kids, you just know that that's true. So I think that that's an element. And then kids who who don't have parents who are present enough, right? They're raised in a different way. It takes an incredible amount of work to raise a psychologically healthy child. We completely underestimate how difficult it is to parent correctly. And we have not been present enough for our kids for decades at this point. And especially when it comes to maternal presence in the early years, and fathers being allowed to come in and discipline and enforce boundaries. And that is not just saying that bedtime is at 8, but enforcing that bedtime is at 8.
Mhm.
So you need two parents. You need a father and a mother behaving as a united front to carry a child into a psychologically healthy adulthood. We've completely underestimated that, and I think that's behind the increase we are seeing in cluster B traits.
Mhm. So, Hannah, it sounds like you acknowledge both a nature, a genetic element, a predisposition, and you have a very clear sense of what you think causes it from a nurture perspective as well. The trauma argument, I heard you say something like that you don't see it because there isn't necessarily a history of trauma in every borderline patient. Some might argue, well, maybe they don't even remember the trauma. I would wonder if, looking at it going forward, if they all had trauma, would trauma treatment treat the borderline personality disorder?
Absolutely not.
Okay.
I've tried.
Okay.
That does not work. It's like treating hypothyroidism with insulin, is what I usually say. That's completely counterintuitive, because you need to sort of try to reverse these behavioral strategies. And what do you do in trauma therapy? You, at least the trauma therapy that's usually given, is that you go over the trauma again and again. I'm talking about the EMDR. You try to sort of master that experience, but that's not, that is not, what happens when someone is traumatized. They have intrusive thoughts about the negative experiences. They remember the past experiences better than other things. That's what causes a trauma response. Not, this idea that we have memories that we don't even remember, and that's giving us the negative symptoms of the present. The data doesn't support that. It just doesn't. Look at the post-traumatic stress disorder patient. They're trying to forget their traumas. And so when you look at and I've looked at the trauma research around the borderline, and they're all self-report from patients who remember their past in a certain way because of the extremely heightened neuroticism and sense of victimhood. So you're those are that's the research that has us thinking that borderliners have been victims of trauma. And if you look at, for example, Joel Paris, who wrote critically about this, if you look at just verified trauma. So if you look at people who do come from childhood abuse, and that's where you want to start, because the borderline traits are visible already at 12, 13 years old. So you can't say, well, I had traumatic experiences as 15, 16-year-old, and after that I developed my borderline. That just doesn't make logical sense. So you have to look at the people who came from very difficult childhood, where there was abuse and real neglect, and there's no consistent evidence that they develop borderline, to the point where we can say that genetics plus traumatic childhood causes borderline.
Okay, so we can say treating trauma doesn't treat it, and they don't necessarily have a history. They don't all have a history of trauma as borderlines. So the treatment that I hear recommended is dialectical behavioral therapy, or DBT. How does that work with borderline patients?
Yeah, DBT has some very inherent flaws. DBT it's elements of cognitive behavioral therapy plus mindfulness plus very intense therapist engagement. So in DBT, you'll have an hour a week individual therapy. You'll have group sessions, and you'll be able to have phone coaching from the therapist. And so that'll cause a sort of attachment between the therapist and the patient. And through that attachment, yes, you can try to move the behavior into a more healthy pattern. The flaw number one is that these are largely female therapists, right? 85% of therapists now are female. And what do females do? They get pregnant, right? They go on maternity leave. They burn out. I'm sorry, that's not something, I'm not saying that to be mean, but I've worked with them. At some point, they do burn out, or they change jobs, they relocate. There's a high turnover in all these clinics. And that breaks the attachment. And what happens then? Patient is back to square one. So that's the flaw number one. The other flaw is that, so DBT has really shown that it reduces self-harm, and it does. It reduces self-harm, and it reduces acute crises, need for crisis intervention. But that's really the data that it has. It does not prove long-term functioning. So it's not like we don't have studies where they follow these patients from the DBT courses. 10 years later, they see, she's able to keep a job, and she's married. We don't have that. There are a couple of those studies, but really very few, where they look at the patients, long term, and they see they've had a range of different structured therapy, and they do sort of get better with the acute symptoms get better, but the functional impairments, they're still present. So in terms of curability from these personality disorders, it's it doesn't look great. And so that's when the therapist then is on the phone with the patient. So the patient, let's say, okay, so the borderline patient has a crisis, calls and says, I really want to cut myself. I'm having suicidal thoughts. That's very common with them. It's one of the diagnostic criteria. They have suicidal thoughts. I'm going to do it now. What am I going to do? Okay, so the therapist, regardless of the time of day, she's maybe putting a kid to bed, doesn't matter. She has to be on the phone and talk her down, and they go through the mindfulness techniques. And then, okay, the crisis is over, and the therapist, who has a rescuer complex, because they always do. That's why we go into these fields. God, I'm such a good therapist. You see, it's really working. And then the patient says, okay, that worked. And goes about it, comes in the next day, they have a session, and they both feel good about themselves. And it's sort of like a little sort of, I give you the reduction of self-harm, so you have the feeling that this is working and you're a really good therapist. And then, we can all say how well this DBT therapy works, but I still don't have an education. I still don't have this. I still don't have that. But we get to say DBT reduces self-harm. So that's, and I saw this from the inside. I was on the phone with these girls. And yeah, what happened? I went on maternity leave, and that was later. First, I went on a honeymoon. I came back, and two of them were hospitalized because they just could not deal with me being away for 2 weeks, and then you have to deal with the fallout of that. One of them came back and had a completely different diagnosis. So that was, but yeah. So that's those are the inherent flaws in the therapy, that you have this unhealthy dynamic forming between the therapist and the patient.
Mm.
And I don't know if we can really attribute those great results to the therapy itself. And the third thing is that they're learning to do more of the manipulative strategies that they had the tendency to do in the first place. For example, this broken record technique that they're learning. I don't know if you've heard of it, if you're familiar, but there's just saying what you need again and again and again until the other person gives in, which would be great if someone has a dependent personality disorder. That's what I would do with that person, not with someone who has the opposite, someone who's so low in agreeableness. All they think about is how to get what I want, regardless if I'm in a crowded train or, out on the street. So I just think when I look at these techniques, I'm just thinking, where's the communal approaches? Where's the thinking about others? That's just not what they focus on.
How do you think that would work?
What would work? Those approaches where you try to I would go with family therapy. These are often young girls, I would try to pull in others and try to sort of widen the horizon a little bit, because they're very inward looking. What am I feeling, and what do I have now, and you know the anxieties I have and my suicidal thoughts. And I would try to focus on doing for others, being kind, contributing to society, really. And that goes for all suicidal patients in general. What you have to do is try to widen the horizon. What would it do to other people if I committed suicide? That's what tethers us to the here and now, to staying. So I would try to have a therapy where it's about action and doing and taking part, rather than mindfulness, where it's about what am I thinking and feeling in this moment.
And with this, it seems that if we were to kind of put an umbrella over cluster B personality disorders as low in conscience and high in manipulation, that anything that they have at their disposal that gets other people's attention is kind of a tool to manipulate. So with the self-harm, that's yes, it is harming the self, but it is also getting the attention of others. I mean, is there really a sense that it's really about something with the self, or is it more about getting stuff from others?
Yeah. Yeah, they are right. It is about survival, as it is about survival for all of us. And I think, yeah, we are all trying to do what works. And just if you're higher in conscientiousness, you're just more able to think about those goals long term. Right, so it's all about the self. But when I think about, okay, what is good for me, that is automatically what's good for my kids and my family, not today, but 5 years ahead. So it's that, what is that self that you're talking about? And now people say it's that the borderliners have a fragile self. I don't know if that might be what you're referring to. And then I just think, like, What do you mean by that? It's this sort of psychoanalytic relic, fragile self. What is that? It only means high neuroticism. That is what that means. If you have one of these therapists describe, what do you mean with a fragile self? All the words that they would use would just, you could put right into neuroticism.
Mm-hmm.
So yeah.
And when we're talking about this, we're talking about someone with borderline personality disorder as a female. When I talk with experts about dangerous men, the borderline male gets sort of lumped in with the narcissist, with the psychopath, that kind of thing. Would you make that same connection with males, or do you think that somehow borderlines are different?
Of course, borderlines, that men can also be borderline, but only if they're very feminine.
Hmm.
Very feminine men can be borderlines, very fragile men. And that's why there just aren't that many of them. And now narcissism has become very popular. Now it's sort of the buzzword, and I don't enjoy this term very much. I think that there's a good argument to be made to remove narcissism from the diagnostics altogether. Because what is it? It's very low agreeableness, and they're high, usually higher in conscientiousness, right? So they're able to follow through. They're able to have some level of ambition, right? They're higher in extroversion, so they have that self-assertion as well. And so, is it a disorder? Right. I've never seen a narcissist in the clinic. They don't usually need that. Why? Because they're quite low in neuroticism. And really, the people who come to the clinic who need, who could fulfill the criteria of a clinical disorder, they're usually higher in neuroticism, because that's where the depression and the anxiety lies.
Hmm.
So I think, that we shouldn't be so focused on narcissism. And the men, of course, men can be borderliners as well, but it's rare.
Yeah.
Did that answer the question?
Yeah. I guess, do you still think that borderlines could be predatory? Are they dangerous?
I think they're absolutely. I think the borderliner is the female predator, just like the antisocial male is a predator. We've no problem calling him a predator.
Yeah.
No problem at all. And we don't victimize him. We don't look at the antisocial male with sympathy. But no one is arguing that the antisocial males should be excused their prison sentences. Nobody's making that argument. And nobody thinks that the antisocial male incarcerated, that we're going to solve that inside a therapy room. It's not. That's not a serious conversation we're having. And so the borderliner is absolutely a predator in that she doesn't care about social norms. She doesn't care about using her fragility, her victimhood to hurt you. That she doesn't have that high need for affiliation, that bonding. She's no problem acquiring a male, right, for resource acquisition, and then throwing him away once there's a better one coming along. Like once, he poses like difficulty. Once he says no, well, you try telling a borderliner no and see what happens. Well, you will quickly be replaced. So because they don't have that bonding, that sense of bonding, they're very low in agreeableness.
They don't have a sense of bonding. So is that something cognitive? It would seem that just naturally as humans, we bond. If we're in a relationship with someone, we have hormones and things that are, kicking up. What is preventing the bonding in a borderline?
Well, it's that the action systems behind the dimensional traits, right? So behind that level of agreeableness, there's that affiliation system that's working. And our need for bonding is in there. Again, that's why I keep saying that with the the dependent personality, right? Who's so dependent because their need for bonding is so high because they're very, very agreeable. That people pleasing that comes from that hyperactive affiliation system, that need for bonding and security, and the borderliners are very low there. So that's why the bonding for them is about resource acquisition, not about that. Not about the aspect of love.
So I'm
Does that
curious.
make sense?
Yeah, I'm curious about the distinction with bonding and attachment, because I've heard you talk about attachment and say at the root of these disorders are attachment needs that aren't fulfilled. So what do you think about these unmet attachment needs as that compares to bonding?
Yeah, we all have a level of attachment that we need to fulfill, right? It's not that they don't have that need at all. It's just not that high. And they just need attachment for a different reason, right? They need attachment because that is they don't have any other competencies. So they attach to men because they're not competent enough to get a degree, to keep a long-term job. So that is the strategy. And same, when they're young, that charm, that way of manipulating to getting what they wanted, that's already there. So that's what I mean by that. They do also have unfulfilled attachment needs because this doesn't develop without parental absence.
So it starts with a parental absence that leaves an attachment need. They're attaching in the sense of partnering or developing a close friend or maybe even having an attachment with a therapist, like we talked about earlier. But the bonding is something different. What is the distinction between attachment and the bonding?
Very little. I don't think you can really make a distinction. I think you can say that that bonding has to do with love, and an attachment is it is more in the level of resource acquisition. That's how I would distinguish them.
Wow. Okay, so it's a very practical strategy, the attachment-ish thing, to attach and to attach and to attach. But in terms of actually
Exactly.
letting the guard down enough to have a romantic, loving relationship with someone
Okay.
that's sincere, that's
Yes.
the threshold that doesn't get crossed.
Yes. So the borderliner, they will go in. They call it love bombing,
Yes.
but it has nothing to do with love.
Yes.
But it is that what can I do in the moment to hook this person, to get this person attached to me.
Yes.
So they'll mimic you, they'll tell you what you want to know. And because they're so sensitive to their surroundings, very high in neuroticism, they're extremely sensitive to cues. So they'll see this, your smallest facial expressions and say, oh, he reacted to that, more of that. And so they're extremely good at triggering that bonding in you, but they don't need it enough not to go from man to man to man, because they still need that, but it's a different need.
Wow.
Do you understand what I'm saying?
Yes.
Yeah. So that's why I use and I toss, and men are disposable. This is why they go through men, because But once they then have you on the hook, then they'll start escalating. And then they'll see how far can I push you, how far, how attached are you, and they'll test you, and they'll escalate. And then if you do as they say. So I mean, should I go through a scenario for you?
Please.
Yeah. So let's say you're sitting on that train with your borderline girlfriend, and she wants something from you. You say, I'm not sure, and I'm busy week, I don't know. And but come on, and don't you love me? And okay, first elevation, first escalation. Okay, I don't know. And you keep saying no because you're really stressed. She doesn't care, right? She's not going to care that you have a stressful week, because she's not self-sacrificing. For that, you want someone who's dependent. And so you keep saying no, and 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 you keep saying no, okay, so this is not her. She's going to continue escalating. And if she'll escalate so far until you say, okay, fine, just stop throwing things around, right? Stop throwing the luggage and go up on the chair, stomp on the chairs. Like, she'll go that far until you acquiesce. Say, okay, fine. Then you're sitting there, she's calming down. She got what she wants. Okay, meltdown over. And then you start thinking, oh my God, who did I attach myself to? Who is this person? And you have all the men will describe this. They have this moment where they think, what did I do? Who is this? She's not the one I met at that first date. And then she senses that in you, you're withdrawing. And she's like, oh, okay, so what did she do? She starts hoovering. And she starts coming back and she starts telling you the things that I love you. She'll start, because she knows what works. And it could be guilt. With parents, it's usually guilt that they use. With men, it's something else. It's sex. In various forms. And then you're on that, and if that doesn't work, let's say you hold the line, she will dispose of you.
Mhm.
And then get someone who passes the test.
Yeah.
So sorry, that's just the way it goes.
Yeah. Well, these tactics may be distinct, but the higher level that you're talking about of putting on a facade and then testing to see how much they can get away with until eventually the target gives up or won't play the game anymore. This is exactly what I hear in talking with experts about predatory men, psychopaths, narcissists, that sort of thing. Why do we treat men and women so different when it comes to recognizing predatory behavior?
Yeah, that is such a good, and that's exactly what I'm working on now. It upsets me very much because we are desperate to see women as victims. Absolutely desperate. I think a lot of it lies in feminism. Right? Feminism trained us to see women as morally superior to men. That there's nothing they could do wrong, and we stopped. We made female behavior unjudgeable with feminism. You're not allowed to tell them how to dress, what is appropriate, how many partners to have. That all came along with feminism. It completely removed any social norms for women. And I think that the borderliner is very good at hiding in that victimhood allowed by feminism.
Yeah. What do you think of feminism in general? What would you say it is? It seems a thing that people have a hard time even getting their hands around. What is feminism?
Feminism, very clearly, it is dismantling the patriarchy. That is what they wanted to do, and they see men and women instead of seeing like class. They see, okay, it's men against women. Men are the oppressors, women are the oppressed, and they started this war that we're clearly seeing now between men and women. And you can go back to their writings in the 1800s. They write very, very negatively about men, about male sexuality. They pathologized male desires and male sexuality, and they put women on a sort of pedestal, right? Where female sexuality was all that was good, that was morally superior, and male sexuality was oppressive. And they made us believe that the site of women's oppression is in the home. That was written by Elizabeth Cady Stanton, the mother of feminism back in the 1800s. That is the site of female oppression. And since then, they waged a war against the family, right? Because that's the site of women's oppression. And so that is how I look at feminism.
Why a war against the family?
Because they look at it as the site of women's oppression.
But
women
why would
have
someone
to be
want
liberated.
to wage a war against the family in general? What would be the motive behind that?
Well, the women, the feminist writers, they were very unhappy in their families. They were they were usually, middle upper class women who were very jealous of what men in their same class could, go and do. And they didn't think about the average woman or low class men. They just thought about what they had and wanted, and they wanted to make women unhappy. Right? That's so. Of course, if you are unhappy in your family life, you generalize that and you say, "Oh, it's because family is the problem. It's because marriage is oppressive, and we need to liberate women." Instead of saying, "Okay, maybe I chose the wrong man. Maybe something is wrong in my attitude, and maybe I should think about my kids instead of myself." So when I read these stories from, Mary Wollstonecraft, they all had tragic, tragic childhoods. So that says something. Right? They're all heavily traumatized. And then they generalized. Oh, it must be true for all women that family life devastates us. And, we see the opposite has happened with feminism. Are women happier? No. Are kids happier? No. Are men and women finding each other? Absolutely not. So that's the result of that, the denigration of family.
What about things, though, like increased education for women, voting rights, economic power, that sort of thing?
Yeah, I think that those things would have naturally developed. There wasn't a lot of time between all men got the vote and women got the vote. A lot happened when women took a lot of responsibility in the First World War. That changed a lot. So you saw a lot of that progression. Did we need the terrorism of the suffragettes? I would say no. They did horrible things that we don't talk about.
I have no idea what those things are. Could you share?
Like they put corrosive chemicals in mail in the mail so that the mail postman would open and get burns on their hands. They placed bombs. Like they would be incarcerated and go on hunger strikes, and then because there were women, they would get force fed, and then that would be in the media, and there would be an uproar because how could we possibly do this to women? They did terrible things. And I would really recommend reading Janice Fiamengo's work. She has a new book coming out now where she details all of this. And it's really things that we haven't heard before. And, regarding voting, the voting, it was really about the draft. And it was really about who gets to decide when and if we send men off to war. And it didn't used to be about being a man or a woman at all. It used to be about owning property. So there are a lot of these nuances that we haven't been taught. We're saying, oh no, it's really about getting voting rights for women. It's really about getting education for women. Like, hello, we had women going to universities in in the 1800s. Elizabeth Cady Stanton herself, the mother of feminism, was very highly educated. Right? She was learning Greek. This is just one of these things that we're told. People always say this: oh, you're a medical doctor. How could you go against feminism when you're a medical doctor? It is such a boring argument. Okay, that's the feminism didn't give us that. That was never the point of feminism. The point of feminism was to pathologize men. It was to make life worse for men, and it was to establish women as morally superior. It's just much easier to say, "Oh, we're going to voting rights," and no, that history of voting rights is much more complicated than that. And I hesitate to say we needed feminism for that at all. Also, has it become better? Has it become better since we all got voting rights? Right? It's yeah.
I wonder what you make of another take on this. Someone else who's been on my show, Dr. Dani Sulikowski. Her idea is that feminism is kind of the mother of many ideologies, and a little bit of nuance. Rather than it being about tearing apart the family, it's about preventing the reproductive success of other women. That it's actually a form of sort of competition among women, and an attempt for some to pass on their genes while they distract others with other things, keeping them working on other ends rather than having children of their own.
Yeah, I've heard that, but the one thing I then would say is, yeah, well, feminists are the ones having the least amount of kids. It's not like they're going and getting settled. So I think that it doesn't really work. Also because feminism keeps morphing, right? It keeps being about different things. It takes on different forms, and now you have just as much feminism on the conservative side, right? And so I think that it's much bigger than just trying to have other women not be successful on the mating market.
Okay. So when we talk about these destructive behaviors in women, what do you think is going on in culture that incentivizes this? I've heard you talk about the problem of incentives.
So we're incentivizing this fast life history strategy, right? We're incentivizing promiscuity, early maturation. Like a big factor when you think about borderliners is that, they become sort of mature, but it's not real maturity. It's this sort of costume of maturity very early on. They become early sexualized, and they'll often have boyfriends who are 10 years their senior. And then they'll go and they'll brag, oh, look at my boyfriend, he's in college, or, I've seen 16-year-olds with 35-year-olds. Here, that's legal. And so...
That's legal in Switzerland?
Yeah, 16 is the age of, yeah. That's not something I would vote on, but yeah, that's legal here. So and they're proud of it, and they're kids are now. We try deliberately to fast track maturation in kids. We like it when kids are independent. We like it when they seem smarter for their age. Why? Because we need to detach from them early on. Right? They're from a very early age. They are in daycare, in school. They have long days. And what we need from them is that they detach from us quickly. So we reward this sort of fake maturation. And I say it's not maturation because what it is social competence. It's this competence of being manipulative, trying to move the environment to satisfy your needs. It's not maturity. It's taking on responsibility and being accountable for yourself. That's true maturity. And so we're very much incentivizing these things. And what we're doing then is we're leaving parents all alone. We're leaving parenting just for the home, where the parents are largely absent, by the way. And the kids are, they're going out, and the norms are not being held. So let me give you an example. You have a 12-year-old girl. She's coming down the stairs in a provocative outfit. And the father tries to say, is that really appropriate? Should you be wearing that? And she's, oh, God, it's just me, and I love this outfit. And if he sort of holds the line, she'll escalate. Oh, you don't know anything, and you're shaming me. And she has all the words, right, from society, all the words to sort of sway him. And the parents are usually split, not in the same home, and if they are, very seldom are they a united front to hold these boundaries. Usually, a parent alone, and then he'll sort of give in or try to sort of be firm, but. It used to be in older structures that society would help the parents hold the line. That she would go out in society and the boundary would be affirmed that this is not appropriate. And now it's the opposite. Now she's given the language to fight at home, to go out and be promiscuous. So that's I think, a good example of how we're incentivizing this sort of fast strategy.
Mm-hmm. And the language too, if you're a parent and you're new to these sort of terms, but they're so loaded, it's good. Immediately when you confront your own child, it's to have a sort of guilt thrown back on you. It would be very destabilizing, I would think.
Yes, exactly. Like 12-year-olds will say, "You're pressing me,"
Mm-hmm.
and they'll use therapeutic language. A lot of them are in therapy. They'll say, "I need my space, and you're not respecting my boundaries, and this is what I need. This is what I need for my mental hygiene." So what are you gonna say?
What do you think are
Yeah.
the effects of the sort of therapy culture that we're in?
Yeah, so that's what I talk about a lot in Psychobabble, that it incentivizes dysfunction directly by giving this sort of language, and language that is only about how can I allow myself to be self-centered. None of it is about how can I contribute to society? How can I build a stable life? It's all about how can I comfort myself in the moment, regardless of others. There's always this sort of what I said about DBT therapy before, this sort of how can I get what I want right now? How can I meet others and sort of stand up for myself? And that's only good in therapy with very specific people.
So,
So I think and we incentivize dysfunction with, in social media, um, with the diagnoses. We've diluted the diagnostic system. That's a big factor. So if you go to a therapist, the likelihood of you coming out with a diagnosis is very high because there are so many that can fit. So, so that's and so the really gradually we haven't just added disorders and diagnoses. We've expanded the diagnoses themselves. So we're adding more diagnostic criteria while making the diagnostic criteria list easier to fulfill. So that's how you get to problems like ADHD and autism. So if you have, you have, if you look at an autist now, as opposed to 50 years ago, they look like very different people. And that's a result of that.
and just to be clear, when you say incentive, what is the payoff? What is coming? Is it sympathy? Is it attention? What is the incentive that people are getting that's present now?
A couple of things. One is that we're making the ordinary extraordinary, right? For example, um, now it used to be you going to work every day from 9 to 5, and that was normal. And then in addition to that, you're expected to have a family life and do things and have like a role in your community or in your church or whatever it is. So there are a couple of things that you'd sort of be expected to do. And now we don't have the same kind of stamina for that. And so we want to, getting a mental disorder, let's say you're then diagnosed with ADHD. If you can say, I have ADHD, but I'm still going to work 9 to 5 every day, that will be applauded. But it's the way of making, but I'm only doing my job, but I'm doing my job in spite of my mental health disorder. So you're making the ordinary extraordinary. And so that's called secondary gains. And it's a way of you have a diagnosis, you get all kinds of accommodations, and you get a redemption arc. So it's, I could have done all of these just extraordinary things had I been diagnosed earlier. I would have been able to achieve that, but I have ADHD. If it wasn't for this. So it's a redemption arc. So you have all these different things, and you have medication, then you have, if you have a therapy, you go to therapist regularly, or you have a once-a-month appointment. The moment you can't handle life anymore, you have someone at the ready to give you a sick leave, to give you a sick note. Then you have a timeout. So it's that. And with mental health disorders, there are no tests you can do. People forget that. You can't do a lab test or a brain imaging and then say, oh, this is that kind of brain. This is your ADHD brain. We don't have that. It's all self-report. It's all subjective experiences told to a female with a rescue complex.
Well, Dr. Hannah Spier, I feel like we are just getting warmed up. But before we wrap this up with one more question, where is the best place for people to look for you online?
Yeah, come to my YouTube channel, Psychobabble, or my Substack, also called Psychobabble.
Excellent. We'll put links in the description for everyone to check out.
Thank you.
And last of all, I'd just like to know, what do you think can be done to help people to recognize and stop predatory women?
Yeah, you need to screen better. That's the work that I'm trying to do. Help men to screen. You need to date with intention and prudence, right? You need to approach dating as if it's a job interview for a future mother. So and also include your sister and your mother. Women are very good at scouting out predatory women, just like with the psychopath or the sociopathic male. Who's best at recognizing them? Your father and your brother.
Wow. Well, an elegant solution. Dr. Hannah Spier, thank you so much for the work that you do, for the courage to do it, and for taking this interview with me. Thank you.
Thank you, Brad.
Thanks for watching my interview. To go even deeper on these ideas, you can watch my episode with Dr. Dani Sulikowski using the link in the description or the box on the screen.